Hello everyone. Today we are going to talk about a topic that's simple in appearance but very powerful in practice, and that is how to interpret lactate levels in pediatric venous and capillary blood gas samples. So we'll break down what lactate actually is, how it behaves in the body when it becomes a concern, and what those numbers really mean for our young patients. So the first question, why lactate matters? Now, when you look at a blood gas, it's tempting to see lactate as just a marker of anaerobic metabolism. But actually, it's far more than that. Lactate actually tells us about tissue oxygenation, it tells us about the balance between supply and demand, and how well the child is coping with any metabolic stress. It's also involved in energy production, cellular signaling, and even immune responses. So, whenever lactate is raised, we need to ask why is it raised? So, at the most basic level, lactate is an organic alpha hydroxy acid that at our body's pH floats around as the lactate oil. Now, what's often surprising is that the lactate isn't just made when oxygen runs out. It's actually produced and used constantly, even when oxygen supply is perfectly normal. So, a raised lactate always needs clinical context, not just a knee-jerk reaction. So, talking about pediatric lactate ranges, the first question is, what's a normal lactate levels in pediatric? Now, for venous samples in children, we generally expect lactate between 0.5 and 2.2 millimoles per liter. Arterial lactate runs at a slightly lower level, usually between 0.5 to 1.6 millimole per liter. Capillary lactate varies by age. Neonates and very young infants can have higher normal levels. For example, a baby under 2 months can have up to 3.5 millimoles per liter of lactate. So we have to match the value to the child's age. Now, in critically ill kids, the lactate might be above 2.5, and that should raise a flag for further close monitoring. A little bit I want to talk about hyperlactatemia versus lactic acidosis. Now remember, not every raised lactate is the same. We distinguish hyperlactatemia, that is mild to moderate rise, say between 2 to 4 millimoles per liter without any metabolic acidosis, has to be differentiated from what we call as lactic acidosis, which typically means that the lactate is above 5 and there is an evidence of metabolic acidosis in the form of a low pH. It's also important to remember that lactate itself isn't directly making the blood acidic. The real culprit is the hydrogen ions, which are being generated during the ATP breakdowns, which would actually take down your pH and cause acidosis. Now, when you see a child with an elevated lactate levels, the first question is this a type A or type B? Now, a type A lactic acidosis means that there is a supply-demand mismatch. Simply put, that means that the tissues aren't getting enough oxygen or not getting enough perfusion. Think of shock, like for example, if it's hypovolemic shock, cardiogenic shock, obstructive shock, or distributed shock. These things can cause type A lactic acidosis, or some scenarios like cardiac arrest, maybe severe anemia, sometimes profound hypoxia, or even sometimes in intense muscle activity. All of these things, they push the pyruvate down the anaerobic pathway, leading to an increase in lactic acid or lactate. The second is what we call as type B lactic acidosis. Now here, the lactate goes up even when oxygen delivery is fine. And this can happen for several reasons. For example, the type B1 lactic acidosis is due to underlying diseases like, for example, malignancy, sometimes sepsis, which can paradoxically cause aerobic glycolysis. It can cause liver or kidney failure. Sometimes it can be due to thiamine deficiency, or sometimes even diabetic ketoacidosis. Type 2 beta 2 or B2 lactic acidosis is what is caused by drug or toxins, or in other words, drug or toxin induced, like things like beta agonist, adrenaline, some drugs like metformin, propofol, cyanide poisoning, or even carbon monoxide poisoning. They can all drive lactate up by blocking normal metabolism or just simply by ramping up glycolysis. While the type B3 lactic acidosis, this is congenital, and this is usually caused by rare enzyme defects that block the pyruvate's next metabolic steps. Uh, Back in 2017-18, Miller and colleagues, they studied lactic acidosis, and their paper offers another lens into the lactate metabolism. It says it focuses not just where the lactate is coming from, but why the lactate is being raised. So the questions usually asked in such scenario is pyruvate production increased, like as for example due to catecholamine surges or because of beta agonist, or is pyruvate underutilized, for example like with hypoxia or enzyme blocks from thiamine deficiency, or is lactate simply not being cleared because the liver is failing. So thinking this way helps us match the cause to the clinical picture, because whenever the lactate is raised, we have to find what's causing this rise in the lactate levels. A little bit I want to talk about the venous versus capillary sampling of the blood while interpreting lactate levels. Now, arterial lactate is the gold standard. Getting arterial blood in kids, especially neonates, is very invasive procedure. It's very tough and usually not recommended. So that's why we rely on venous and capillary samples more often. So venous lactate generally tracks well with arterial levels, especially below 2 millimoles per liter. But if the venous value is higher, then one can consider confirming it with an arterial sample if that is practical. Capillary lactate is quick and handy. We usually do it in neonates by heel prick, but its accuracy can drop in state like shock, where peripheral vasoconstriction just skews the result. Maybe sometimes sort of a squeezed heel prick can also lead to rise in blood lactate levels. So accuracy actually matters, and it's important to understand what affects accuracy, because when we are interpreting a lactate level, we have to remember the pitfalls. For example, if you have a struggling child and a hard blood draw, you might see false high lactate levels on the blood. Let's say if you have applied a tourniquet and if it's left on too long, that can locally raise lactate. And sometimes if you delay the analysis, the red blood cells keep metabolizing glucose, so lactate drifts up. So a quick analysis of the blood sample, ideally within 15 minutes, or you can use special tubes which helps keep it accurate. A little bit about sepsis and shock. The thing is that where lactate levels they really shine is in sepsis and shock, because there it's a key marker of how well tissues are being perfused or not being perfused. So in children with septic shock, a raised lactate level is an early red flag for higher mortality levels. But it's not just a snapshot, because tracking lactate trends and lactate clearance over a period of time is a much stronger guide to prognosis, just as compared to taking a single number. Also, we rely on lactate levels, especially we are dealing with trauma cases and burn cases, because the persistently high lactate levels in trauma and burns patients hints at occult hyperperfusion. It means the tissues are still starved for oxygen even if their blood pressure looks fine. Higher lactate correlates very well with worse injury or worse injury severity, with higher risk of infections, with organ dysfunction, and even with mortality. And some of the other scenarios where high lactate can occur, it's usually after a seizure or intense exertion. In these cases, a child's lactate can spike, but it usually normalizes within 1 to 2 hours after the cessation of the seizure. Now, this quick fall helps distinguish, for example, an epileptic seizure from syncope or febrile seizure. Thiamine deficiency is another culprit. Now, you can think about malnutrition, sepsis, or prolonged vomiting. Toxins like carbon monoxide or cyanide can also cause extreme hyperlactatemia. Usually, in these cases, the levels are over 10 millimoles per liter, and that should ring alarm bells for a possible cyanide poisoning. And when you see persistent elevation without hypoxia, always consider a metabolic disorder, especially if you find high lactate levels in neonates and infants, and otherwise they seem fine. And when we are talking about neonates, a little bit about neonatal specifics. Remember that in neonates, the baseline lactate can be higher. I told you that even up to 3.5, up to in kids up to 2 months of age is normal. And remember, umbilical cord lactate level in neonates is a powerful marker of how well the baby tolerated labor, and sometimes can predict outcomes like APGAR scores and in conditions like hypoxic ischemic encephalopathy. So, I would say one of the most important take-home messages is that a single lactate value is useful, but serial trends are far more powerful. Also remember, a falling lactate during resuscitation simply translates into improved survival. Similarly, failure to clear lactate in a septic child or a trauma patient is linked to worse outcomes and longer stays in the hospital. While we don't have a strict target for clearance, normalizing lactate as quickly as possible is a good rule of thumb. So in summary, always interpret lactate levels in the context of the child's age, in context of its clinical condition, and in context of trends over time. Remember, venous and capillary samples are practical, but also know their limitations. Remember, use serial measurements to guide resuscitation. And above all, never treat the number alone, always treat the child in front of you. So this was all about interpreting the venous and capillary lactate levels in kids. Thank you for your attention. And if you've got any questions, put it down in the comment section below. I will answer them as soon as possible. Have a very good day. Take care and bye-bye.